Hello everyone, this is Ryan Napolitano with the Lexer Lab Group. In this video we're going to talk about the next steps after we have confirmed a passively seating verification jig. As you'll recall with this case, we have 4 implants and we're hoping to do a hybrid denture. As we go through our diagnostic process, and as we talked about earlier with our AP spread, you can see that on this model we have a few small markings that we've made in the anterior and through the posterior implants. Now this happened to be about 11 millimeters, so doing our math out, we have cantilevers here of 16 millimeters on either side. And you can see that from where we are, that is a good safe distance to cantilever our restorations so that we can not only not stress out the implants, but not stress out the restorative materials over time. When we do these cases, we're going to start by creating a basic denture setup on here. We already have our existing occlusion. These are basic denture principles, and we're going to just set up teeth normally. But a word of caution, it's important to understand this AP spread and take this into consideration when you're doing your setup, because this will determine if we can get to second bicuspid, first molar, or second molar occlusion. When we talk about expectations with our patients, if we understand the AP spread and how far back we're able to go at this point in time, we can set up our denture accordingly with the same amount of teeth on here. This way the patient doesn't see second molar occlusion in their initial setup, but due to a lack of space when we were doing our implant placement, the final restoration may only go to the first molar or the second bicuspid. So it helps us to not only understand what's achievable for our final restoration, but it also gives us a little bit more security when we're dealing with patient expectations. So after an initial setup is done with a wax rim and denture, using simple denture principles, that setup is then converted to a screw retain setup here at the laboratory. We'll take the exact tooth position and occlusion and simply add in our multi-unit titanium components underneath and create access holes so that this can be then a screw retain setup, as you can see right here. Now, looking at this, you can see that we have met our AP spread expectations on the patient's lower right, but we're a little bit short on the patient's lower left. One thing I will say is that if you see where this line is, right here and right there, we don't have enough room to put on a second molar. If the patient desired, we could probably put a third bicuspid on either side to bring this back. But when we look at this case, we do see that we have a full complement of dentition with the opposing arch, with the exception of the second molar over here. So we may want to have a conversation with this in regards to moving this back, and maybe we can pick up the first half of this molar by sliding this tooth back ever so slightly and putting in the third bicuspid here, or we can leave the arrangement as we have it right now. And that's really an aesthetic call between you, the clinician, and the patient. Chair side, you want to screw this case down using all 4 screws so that we're fully affixed, and you want to check everything as if it was a final restoration. Areas of concern here, obviously, we want to see a passive fit. We want to see even balanced occlusion throughout the restoration. Additionally, areas to consider would be the fit of the appliance to the soft tissue. On the maxillary cases, it's important to have the patient smile very wide and see where this transition line is, so that doesn't affect the aesthetic outcome of the case. And then for both maxillary and mandibular restorations, it's important to understand how the lingual architecture feels to the patient. Now, this being a wax up, obviously it's thicker than the final restoration will be, but we want to get an understanding of any areas that could be problematic now so that we can try and address them in the final restoration at the seating appointment. So we want to understand if there is any impingement over here, if the tongue is able to move freely and we're able to achieve our phonetic goals. Normally S's, T's, TH sounds, P's and F's all have an effect when we're looking at tooth position. So everything that you would evaluate from an aesthetic and functional concern with the final restoration, we should be addressing at this point as well. At this point, this is the duplicate, or I should say this will be the duplicate for the final restoration, and this blueprint will be followed as closely as possible in the laboratory when we transfer this from wax and denture teeth to zirconia or Emax or the other restorative material for the final restoration. So we should be spending a fair amount of time with this and trying to get as good of an outcome in this setup as possible. Now, a few considerations when we look at this case. You can see that our restoration is not screwed on, but you can see that our plane of occlusion is a little bit irregular on this side over here, and that goes in with this older partial that's in place. So when we evaluate this case, one of the questions that I would be asking is, what's the life expectancy of that first molar there? What's the life expectancy of the partial here? If we're planning on redoing the partial over time, I would suggest bringing this plate of occlusion down into a more normal position and leaving that bite open so that we have restorative space when we create a new restoration here. Or if this tooth doesn't have long for the world and is a poor prognosis, we may consider enamelplasty on this tooth and raising that molar up into occlusion to even out the plane one way or another. All things to think about when we're looking at the try-in and how this restoration is going to look in the mouth. So you can see that we're fairly normal on our occlusal plane other than the patient's lower left side. Midline appears to be good. We'll be double checking that at the appointment. And fit to the tissue seems to be good. With the fit to the tissue, you want to have the wax up and the final restoration able to pass floss underneath and be cleansable, but you don't want necessarily enough room where you can see daylight through the restoration in the tissue. My goal is to be able to get a floss threader and super floss through the restoration, or have the patient successfully use a water pick for home care. And that's all the information that we would want to cover at the try-in with a restoration of this sort. Additionally, for those who are inclined, you can check excursive movements and see where you are. For my taste, I tend to prefer group function where possible on these restorations, especially with denture tooth restorations or traditional hybrids. This way we can control the amount of force that's being applied to any one part of the restoration. You can see we have nice group function on this side. This side, because of the nature of the canine, we tend to have a little bit more canine guidance on this side, but we are picking up that first bicuspid just a little bit too. There we go. Thank you so much. Hope you enjoyed.